Continuing education credits for physicians and other healthcare professionals are provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information. The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed in this podcast are solely of those of the hosts.
Welcome back to the Cribsiders. I'm Chris the Chi-Man-Chu, and I'm joined tonight by my co-host Sam and our producer Ha. Hey guys.
Hi.
Hey.
Tonight, our guest is Dr. Ann Marshburn, and she is here to discuss a very common recurring fear for many pediatricians boarding a plane. What do we do when there's an in-flight medical emergency? But first, Sam, do you want to remind us what the show's about?
I'd love to. So we are the Pediatric Medicine Podcast. We interview leading experts in the fields to bring clinical pearls, practice-changing knowledge, and answering lingering questions about core topics in pediatric medicine.
Today, we have a fantastic conversation about how to handle in-flight emergencies with our guest, Dr. Ann Marshburn. Dr. Marshburn is an associate professor of pediatric hospital medicine at UT Health Science Center in Houston, Texas. And prior to medical school, Dr. Marshburn spent several years working in the life science division at NASA's Johnson Space Center and participated in neuroscience research conducted on astronauts. During that time, she also earned her private pilot's license and flew airplanes around Texas and Massachusetts. That's right, she's a pediatrician, a NASA expert, and an ex-pilot. She's here to teach us how to stay calm when the seatbelt sign is on, why you might be the most qualified person on board, even if the last time you triaged a geriatric patient may have been at medical school, and what to do when the guy in 3C becomes acutely ill at 35,000 feet.
Should we get into the case or get into the episode?
Well, we are cleared for takeoff, so let's taxi into this case.
Let's hope we don't crash and burn. Hello, Dr. Marshburn. Thank you for coming on the show. First, because we're an informal group, is it okay if we call you by your first name?
Yeah, absolutely. Call me Ann.
Excellent. So let's start with some quick questions. For our audience to sort of get to know you a little better, could you say a little bit of something about yourself and maybe something outside of medicine that you like to do?
Yeah, so I am a pediatric hospital medicine physician at UT Health in Houston. I practice at Children's Memorial Hermann Hospital. I'm also the program director for our PHM fellowship there. In addition to that, I am the medical director for our pediatric oncology service at the hospital. Outside of medicine, most of my time is dedicated towards working out on the Peloton and traveling. I am also married to a NASA astronaut, and I'm the mom of an awesome Brown University graduate.
There's so many places to go from here.
Yeah.
I thought we were going to go oncology, but instead we're going to go NASA. How's your PHM world interacted with NASA?
There hasn't been tons of, medical overlap. It's been more supportive overlap. There's been certainly a lot of patients that I've gotten close to that find out about my husband. And so we form a little, supportive things that we'll do for the patients. Sometimes I've had a couple of calls that actually come from space for particular patients.
Whoa.
That's pretty cool.
That's awesome. I got nothing better than that.
I would love to know what's the best piece of advice you've ever received as a learner and as a teacher in your career, especially having worked with NASA and in medicine.
So, both of those actually come from medicine. The best piece of advice that I got as a learner was actually from one of my attendings during residency when he sat me down and went over piece by piece every bit of an H&P outside of the assessment and plan, which is what we talk about so often during rounds. And I found that later in my career, I look back on that lesson and it really makes me be a lot more intentional with my documentation and my communication. And it's something that I try to do with all of my students as well. In terms of advice in my career, I think the biggest piece of advice that I've gotten or lesson really that I've learned is how to graciously accept feedback. We can all look at feedback as something that we say, okay, well, I guess I'll get better at that. Or sometimes we think of it as, something that we'll approach defensively. But I always like to look at it as there's a kernel of truth in whatever feedback I get. And I try to search inside of me and find where is that little piece of truth coming from and how can I start to change my behavior to address that?
Oh, that's fantastic. Giving and taking feedback is so important even outside of medicine. So I always definitely try to take that type of thing to heart. And I think thinking that, maybe there might be a kernel of truth. That's a great thing to think about.
I would like to spend just a minute talking about and your background, because I think your career trajectory is really unique. Could you tell us what you did before becoming a pediatrician and how you became a leading expert on this specific topic about, addressing in-flight emergencies as a doctor? This doesn't usually come from the perspective of a pediatrician.
No, it doesn't. And I want to address it as coming from the perspective of somebody who's not an expert in that field, because I think that that's probably more applicable to the majority of physicians who are on an airplane. My trajectory to where I am now has definitely been a bit unusual. I always knew that I wanted to be a physician starting in second grade when I knew that I had to be something. But it was really in high school that spaceflight really started to pique my interest. And at that point, I really wanted to be an astronaut. So actually, during college, I ended up doing a co-op. So I alternated semesters between going to school in Boston and then working down at the Johnson Space Center in various capacities. After I graduated undergrad, I ended up working at NASA in Johnson Space Center in Houston for about 2.5 years. I worked primarily in the neurosciences and life sciences area, doing research on astronauts. During that time, I also got my private pilot's license, flying around, mostly around Texas as well. At that point, then I went on to med school. Actually, the day before I got into medical school, my husband, who is a former NASA flight surgeon, he got into the astronaut corps. So we started our medicine and astronaut careers together, and everything has been coupled ever since.
That is incredible.
Oh, that is quite a story. Yeah.
I think the rest of us feel a little under ambitious now.
Yeah, absolutely. Absolutely.
So actually, as a tidbit, my husband and I actually met in zero gravity. We met floating around the zero gravity airplane. I was an intern at the time and he was a flight surgeon. I can't take the anti-nausea medications that most people take. And so he had to talk to me about that. And in the end, he was impressed that I didn't barf.
Right. Don't they call that the vomit comet?
They do.
That's the best meet cute story I've ever heard.
That's quite a story. Absolutely.
All right. Guys, thank you so much for that. I am going to go ahead and just jump into our not so typical case at Cashlax, or rather what happens after we finished a long stretch of shifts at Cashlax.
Hey, Cribsiders listeners, are you a pediatrician ready to focus on what matters most, your patients? Well, the Permanente Medical Group in Northern California is seeking pediatric physicians to join their multidisciplinary practice, serving families across 21 medical centers with an 80-year legacy of excellence. So here's what sets them apart. No RVUs, no billing headaches, no practice overhead, just you providing exceptional care in a physician-led, mission-driven environment. They offer flexible schedules, a competitive salary and benefits package, moving and relocation assistance, and Northern California home buying assistance. Plus, they are PSLF eligible. Whether you're drawn to Northern California's natural beauty, year-round recreational amenities, or vibrant communities, they have locations you'll love to call home. Visit northerncalifornia.permanente.org to learn how you can help them fulfill the promise of medicine at Kaiser Permanente, Northern California. Again, that's northerncalifornia.permanente.org.
So you finished your long stretch of shifts at Cashlax Children's, and you are now on board a plane headed to Hawaii for a glorious, well-deserved vacation with your family, Anne. You are relaxed, sipping on a glass of bubbly, falling asleep. And an hour into the flight, it happens. The dreaded moment, a gentle ding, and a crew member's voice overhead asking, "Is there a doctor on board? If there is a doctor on board, please press your call button." Now, how many times has this happened to you, and when was the last time it did?
I actually fly a lot. And so relative to the amount that I fly, it's happened very rarely, probably about a handful of times. One time, actually, we were even on the ground before we left, so that was pretty convenient. Most recently, though, I think it was just a couple of months ago, I was flying home, and actually the call never went out because it ended up being the gentleman right behind me, and I just heard a commotion happening. I stood up, turned around, and just got involved right then. Luckily, the person right in front of me was a trauma surgeon. And so she jumped in with me, and the two of us just started working up our patient together.
And I was going to say, I think this is a good poll of the audience group for just all of us who are on this recording now. Like, how many times, or what are the odds that this is going to happen to anybody? This has certainly not happened to me, and I will say ... yet. And obviously I will be much better prepared the next time this ever does happen. But I was just curious, between all of us here, how many times has this happened to you
Twice
guys
for
too?
me.
Twice for Ha.
Twice.
Chris, what about you?
Nothing in flight. I always get the people who are seizing at the family restaurant, but it's never the in-flight emergency.
Yeah. And yeah, so 002, and then obviously, and a little bit more than us. And so, what do you think the odds are in general that this happens to us?
So it's still pretty rare. One of the problems is that there's not a great database that keeps track of everything. So really tracking that epidemiology can be difficult. But, if you imagine the data says somewhere around 3 billion people are flying annually now, that comes out to 8 or 9 million people per day on planes. So you have to imagine that every day there is a medical emergency happening, with 9 million people. The data that I've read, though, as to how often it really happens is really sketchy. I've read between 1 in 40 flights have one, and between 1 in 600 flights have them. So it's hard to say, other than it's rare.
Is there any published data on the odds that this will be a pediatric patient you're called about versus an adult?
So again, it's hard to get that data because there's no centralized database. Pediatric certainly is the least common type of medical emergency, for better or worse, right? And usually when it's a pediatrics patient, it's going to be something like nausea, vomiting, fever, although I have heard of a couple people responding to a pediatric seizure. So maybe, Chris, you'll be ready for that one.
I was going to say, guys, it's because we do such a good job in our primary care job that these kids just don't.
I know.
They don't have any emergencies when they fly. We do such good preventative medicine.
In my mind, it always seems like it's always like, an elderly person who has chest pain or some sort of cardiopulmonary issue. But is that more likely, you think?
So the most common type of medical emergency really that you're going to come across is pre-syncope or syncope. That is then followed by respiratory problems. The next most common is going to be nausea or vomiting. Then you get to cardiac and seizures. Both of those are pretty rare. Again, the data's not great, but both of them are like less than 10% of medical emergencies.
So a lot of times, so like in our case here, you may not always be sitting right in front of the person who's having the issue. And if they ask for a doctor on board, like, what is this something that we ethically should do as physicians to hit that call light? Or, as in our STEM, you just had a glass of bubbly, like you may have taken a little alcohol. Does this also affect your ability to think that, ethically, should I be able to do this? Can you discuss that a little bit?
Yeah, so, the ethical considerations and the legal considerations are obviously different. The ethical considerations, I think that in the theoretical situation, not this theoretical, but in the global theoretical situation, we would all assume that we have the ethical duty to step forward and help. That's why we took our oath. That's what we do in general. The legal considerations, well, that's actually a little bit more challenging to define because that's not just going to be a black and white thing. It's not just dependent on U.S. law. Many of us are flying internationally. So the legal consideration could be dependent on the country you're flying over, the flag under which your aircraft is flying, or a lot of other considerations. So that is not necessarily something that's going to be obvious immediately. And really, you have to make your best judgment at that point as to whether or not you are the right person to be responding to this.
Most of us aren't going to be as familiar with maybe the flag that our airplane is flying under. So I'm curious to know, are there protections in place for physicians who respond to in-flight emergencies from the U.S.? Have there been lawsuits or controversies in the past for physicians that respond to these requests for help?
Yeah, so first talking about not being familiar with the legal considerations and with regards to the flag under which they fly. A funny side note is that I was talking to a United pilot about this not too long ago who would frequently fly from the U.S. to international locations. And I asked him, what he knew about what were the legal ramifications. And he just said, I don't know. So it's okay that we don't know because even the pilots don't necessarily know. The flight crew might not necessarily know. In terms of protections, at least within the U.S., there is the Aviation Medical Assistance Law of 1998 that is basically the Good Samaritan law on a plane. And so basically, it's protecting anybody who acts as a Good Samaritan from any kind of litigation, as long as certain criteria are met. And basically, as long as the person is volunteering in good faith, they're not engaging in any willful neglect, or they haven't asked for compensation ahead of time, they're not going wildly beyond their scope of practice, that sort of thing. So like I said, basically Good Samaritan law on a plane. I'm not aware of any major lawsuits that have happened. That's not to say there hasn't been one, but I've never heard of one. So I would think that they're pretty rare if they even exist at all.
So you said something about scope of practice, and the Cribsiders is a pediatric podcast. So I know we have all sorts of people who listen to our podcast, but I think there may be a large portion of our listeners who are just straight pediatricians or pediatricians in training. And as we discussed before, there's a high odd that it probably is not a child having an issue. How does one think about scope of practice in that situation?
So even though we're not trained to take care of adults, you have to step back and remind yourself as you're walking to the patient that we are still far more medically qualified to be helping this person than the insurance agent who is sitting next to you. So we're talking about scope of practice in the initial, helping an intervention in terms of, am I able to adequately look at a patient, use medical terminology to describe what's happening, and to converse with the ground-based medical support, which we can talk about in a little bit, and have them direct me to do things. Going beyond the scope of practice would be like, hey, I'm going to shimmy up some kind of chest tube with what medical equipment I see here. And that's probably beyond the scope of practice. Again, there's not going to be a definite, checklist of what's in or out. It's really a feel, but going to assess the patient initially is definitely within our scope of practice.
And I think along the lines we're talking about of maybe when we wouldn't, I think it's worth talking about the alcohol conversation, right? We'd started talking that, hey, there was a glass of bubbly involved here. Is there any point that you would say, hey, this is probably unsafe for me to help, even though I probably know more than the average person, I might not be I might not be at my best. Where does me at 50% operate compared to me at 100%?
That's honestly, it's going to be a personal judgment call that I don't think any of us are ever going to be able to ask, what if this happens on the side of the road and you're coming home, you're in an Uber and you're coming home from, a night out with dinner or something like that. So it's something that only the individual can answer at that time. I think in one of the pre-readings that you guys had, there was an article by, I think it was Ruskin, that does pose that theoretical question of, is the physician who had one glass of wine better than no physician at all? I can't answer that. That can only be answered by the individual person.
So let's say we do press the call light and they tell you to come up to the front to help a patient and you're following the crew member. As you're walking and even before you reach the patient, what do you need to know about available resources on a plane? And what do you have to work with? Are there certain things that every plane will have? Or are there limitations that we should know about?
So first of all, I'll have to correct the scenario in just a little bit in that most likely the medical emergency is going to be in the aft or the back of the plane. The flight attendants really try as much as possible to get the person in the back of the plane because they don't want a crowd congregating near the cockpit. But in terms of what you're going to be thinking about as you're walking up, first of all, reminding yourself you are more qualified than anybody else, approaching it like we approach any code. Take your pulse first, take a breath, and then approach the patient. So you can think about the resources that are available in terms of what people are available and what equipment is going to be available to you. When you're walking up and thinking about what people are available, you're likely to not be the only person that's responding. Flight attendants are required to at least have BLS certification, so they can help with that. And usually there's going to be some other doctors or EMTs. I mean, it's great if an EMT is there. This is kind of their bread and butter, responding to an emergency out in the field. That's great. Or nurses. There's been respiratory therapists around before. So you find out who else is around you and try to assess what skill sets are there. In terms of what equipment is going to be available, all U.S. aircraft are required at least to have an AED. In addition to that, there is an FAA required kit, medical kit, that's going to have a combination of required medications as well as supplies. And the medications are both prescription and non-prescription. There's aspirin, diphenhydramine. There's some non-narcotic analgesics. There's usually some form of epinephrine, some IV tubing, some bag mask ventilation, some normal saline bolus, a 500 or 1,000 ml of normal saline. I think what's more important to know is what is not required to be in these kits, and so what are we not going to be finding? It's not required to have any kind of antiemetic, so there is no ondansetron. It's also not required to have any kind of anti-seizure medication, so no diazepam, no clonazepam, anything like that. It's also, a lot of them will have OB clips, so clips to clip the umbilical cord if you need to, but they don't have bulb suction. So that's always something just to think about in the back of your head. And they also don't have pediatric sized equipment. So they don't necessarily have a pediatric airway. They'll probably have a pediatric mask for doing bag mask ventilation, but they don't necessarily have a pediatric airway. And they don't have pediatric dosing recommendations. Now, that's something that can be overcome by talking to your ground-based medical support. But that's the type of equipment that's going to be available. There are other equipment, other things that may be in these kits, and that's going to be purely based on the airline and the aircraft. I've been on an aircraft that had a glucometer. It didn't work, but it was there. And so you may find or hear of other aircraft that have different supplies in their kits. It's just not universal.
So you just said something I want to ask about. So you said there was a glucometer once that you saw and didn't work. So, in my clinic, we have this emergency bag that we always update, and we make sure all the medications are updated, they're not expired and things like that. You said there are medications, there's fluids, there's all this stuff in these kits. Like, does the FAA require them to be maintained? Like, is it possible things in there could be expired or whatnot?
Yeah, I'm not sure what those requirements are. Most commercial airlines and all the commercial airlines that we're all going to be flying on in the U.S. do contract with ground-based medical support that I've mentioned. And so that ground-based medical support is also giving guidance and recommendations to the airlines as to what they should be supplying in flight as well. I would assume that kind of oversight exists, but I haven't read any literature that says yes or no. I'm not sure if maybe this was just a one-off that the glucometer didn't work. Luckily, I didn't actually need it because the guy came too, but sure would have been nice to have.
The glucometer is a nice stepping point for a lot of our questions, I'm thinking as well. Do you ever ask other people on the plane whether you can borrow some of their equipment? So, for example, I'm sure there's 50% of people with diabetes. Yeah, you were very, very close. Is that common? Is it not common, whether you choose to do it or not? Where does that kind of fall in our in the expectations?
Yeah, I was this close to asking passengers for a glucometer because I am sure that somebody had one. I have heard of other people asking passengers for bronchodilators or the auto-injectors of epinephrine. Bronchodilators should be available in the kit, but again, it can be variable. Auto-injectors of epinephrine are not required to be there. Just a vial of epinephrine and then needles are there. So an auto-injector would be helpful. Probably if it were me and I was sure that I needed that and that it was going to be helpful, and I had discussed that with the ground-based medical support, I would think about doing that.
Whether this is your first episode or you've been with us since day one, you know our goal has always been to share clinical pearls and practice-changing knowledge about core topics in pediatric medicine. So let's talk about something that actually changed my day-to-day as a pediatric hospitalist: FIGS. I can't walk into a clinic or hospital without seeing people in FIGS scrubs. And I get it. I wear them too. They're incredibly soft, form-fitting, and durable. And it's not just us. If you've been watching a certain popular emergency room drama on TV, maybe based in Pennsylvania, yep, they're in FIGS too. These scrubs get it. That's what drew me in and what keeps me coming back. And because we work with kids, and kids come with messes, I love that FIGS are antimicrobial. When stuff gets on your scrubs, and it will, you just wash them and they come out wrinkle-free. I've washed mine over 50 times and they still look brand new. Now, with the holidays right around the corner, it's a perfect time to treat yourself to some fresh looks for the new year. Which is great because FIGS just dropped a ton of new limited edition colors and styles for this season. And so, Cribsiders listeners, if you want to check them out, FIGS is offering 15% off your first purchase at wearfigs.com with the code FIGSRX. That's wearfigs.com, code FIGSRX.
Knowing all of these limitations on airplanes, do you personally ever carry your own medical supplies in the event of an emergency? And do you have recommendations for other resources or apps that you think we should just have on our phones in case this happens?
Yeah, so one piece of equipment, honestly, that would probably be the most helpful to you is a blank sheet of paper and a pen. And that's for you to be writing down interventions that you're doing or, vital sign changes that happen that you can then give to EMS if you need to once you get on the ground. Carrying other stuff, honestly, I haven't found to be helpful. Long ago, I used to always have my stethoscope in my purse just because that's where it lived. But honestly, using a stethoscope in an airplane, it's really hard to hear anything. So I gave up on using that, and it just mostly lives in my work backpack anyway. There are certain things that you can bring. There's some portable EKG apps and little monitors that you can buy that aren't that expensive. I have a friend of mine who's responded to a lot of medical emergencies, and he does carry that. I haven't found that I really want to use my precious carry-on space for that. On the most recent medical emergency that I responded to, I tried to use my smartwatch to get a pulse ox on the passenger. It was a little funky trying to do that. Also, I forgot how to get the pulse ox on my smartwatch because I hadn't done it in a really long time. But that is one piece of equipment that you might want to think about having.
So there's no pulse ox in the supplies. So you have so it sounds like the only electronic-ish type thing is an AED, which I assume doesn't have a screen, so you can't actually look at like a waveform. It'll tell you is it a shockable rhythm or not.
Right. Yeah. So AEDs aren't certified to give you any kind of rhythm. Maybe you'll see one and you can interpret it, but it's not going to be terribly helpful. But yeah, a pulse ox is not required. They will have an oxygen tank as well, usually. Again, not guaranteed. The most recent one, they brought out the actual tank. It had a non-rebreather on it, but it seemed like the flow only went up to about 3 or 4 liters, so it's not going to be a massive amount of flow. Some people will consider thinking about the overhead oxygen masks, but that's not a viable resource because the overhead masks, first of all, you can't just selectively drop down one mask. It's an all or nothing. Everybody's drops or nothing. And the masks aren't hooked up to some big oxygen tank somewhere. They're actually hooked up to these individual canisters right above the seats that when the mask drops down, that activates a chemical reaction within the canister that then produces a limited amount of oxygen. And what it's really intended for is a time-limited amount of oxygen to allow the plane to descend to an altitude where the partial pressure of oxygen is physiologic and breathable, and everybody can take their masks off. So on the order of minutes.
Gotcha. So outside of like all these, physical limitations, resource limitations, like are there, and we sort of talked a little bit about the types of things we may see, like are there any specific issues that or challenges that we'll see specifically in like an aviation environment? Like I remember once that I had a patient, and one issue for him was he could not fly to his daughter's wedding because his COPD was so advanced that his oxygen requirement was too high for him to go on the plane. Like, I mean, I assume those types of things are sorted out before it happens, but like does altitude and pressure and things like that, does that create problems that we may see in flight as an emergency that we normally wouldn't see other times?
Yeah, so there are things related to the flight and the cabin environment that affect medical emergencies, and there are things that are related to the passengers themselves that make things more likely to happen when they are traveling. So if you think about what's happening in the cabin, one of the first things you think about is reduced oxygen. So all of the major commercial airliners are flying at about an altitude and the equivalent oxygen altitude of about 6,000 or 7,000 feet. So think about, hiking up in the Rockies, and that's basically the amount of oxygen that we're all getting when we're flying. It's not a problem when we're all just sitting down. But if you took your pulse ox while you're sitting down on an airplane, it might be like 95, 96, whereas on the ground, you're usually at 100. So that can certainly cause more tachypnea, fatigue, tachycardia. Also, patients who are really dependent on higher levels of oxygen, cardiac patients or sickle cell patients, might be more prone to having a problem when the oxygen level is lowered. In addition to that, we also have reduced pressure. So of course, air under reduced pressure is going to expand. So any trapped air is going to expand. And our classic thing that we always think of is the middle ear. So the air expanding, the babies are crying, but that can certainly lead to a ruptured TM. Sinuses, if you have a little bit of sinusitis, that can lead to pretty severe toothache. If there's any air in the pleural cavity in your COPD patient, there's the risk of having a little bit of air in that pleural cavity, the pleural space, that could become a full up pneumothorax. And then, there is an increased incidence of medical tourism. So people flying to different places and having surgery and then flying home. And so you have to think about what type of surgery have they had and how is that introduced air into a space that doesn't normally have air. So abdominal surgeries, any kind of surgery on the chest, ocular surgeries, all of that can introduce air that can then expand when you're at altitude. Rarely do we have to think about medical devices, but you can think about, if you have an insulin pump, which should be nicely sealed and not susceptible to problems. But if there was some kind of leak or something and air got inside it, you could potentially have a malfunction of an insulin pump, or somebody who has a trach in the trach cuff, malfunctions or breaks or something. So you have to think about those things. And then two other things related to just the cabin environment. There's turbulence, which can cause just obvious trauma, even, in lesser turbulence. If somebody is not standing in the right place or just happens to, be next to the bathroom door and gets hit or something, as well as just prolonged immobilization, increasingly long flights. People are sitting in economy for a really long time. Prolonged immobilization, as well as somewhat of a relative dehydration, can lead to an increased risk of having a DVT and a pulmonary embolism. So that was the cabin environment stuff that will increase the risk of having a medical emergency. Then there's the passenger-specific stuff that would increase the risk. So there are, circadian rhythm differences that just predispose somebody to have a little bit more stress on the body. People who are required to take medications at certain times might not be taking them at the correct times. And so they're predisposed to having side effects or not having their medical condition completely covered. People do sometimes have a relatively dehydrated state. The cabin is fairly dry and not humidified. And then a lot of people will dehydrate themselves so that they don't have to get up and go to the bathroom as often. And so that leads to some dehydration, which is going to lead to more medical problems. And then even though we hear it over and over again, I can't tell you how many times I've still heard of somebody who puts their medications in the checked luggage. And suddenly there's a delay. They were stuck overnight somewhere. They couldn't get to their checked luggage. And now they don't have their regular medications. They don't have access to it. And we now have a medical emergency.
Those are really helpful considerations. So many factors that I personally hadn't thought about that would affect how I approach care. Let's say we're at the rear of the plane now. Somebody's called us over to assist because their mom is diaphoretic, a little bit dizzy, says she's lightheaded. And what should we be doing, thinking about how should we triage this adult?
So the first thing after you've taken your own pulse and you've looked around to see who can help you, right? Laying the patient down really can solve a lot of the problems because most of the medical emergencies are pre-syncope or syncope. Just laying the patient down is going to oftentimes make them feel so much better. Ask for a little oxygen to see if that's also going to help them feel better. You can also start asking the crew, do you have a medical kit on board? Is it all right if, we're able to open it? We're not in charge of who gets to open the medical kit. We're used to being in charge because we're doctors and we get to say if the code card is opened or not, but we're not. And we have to defer to the flight attendants.
All right, so I'm going to take this case a little bit deeper here. Let's say she's still diaphoretic, of course, but now all of a sudden she's complaining of crushing left chest pain. Maybe it's radiating down her left arm. As a pediatrician, we don't see that many things that we'd be concerned for MI. What's kind of our next step for triage, and who can we ask for help?
So the main thing to remember is that you're not alone. You've made the initial assessment. You have an idea of what's going on. You don't have to come up with the next steps because the ground-based medical support is there for you. So at that point, I would tell the flight attendant, hey, we need to contact the ground-based medical support because I need help with this. This is not something that I normally deal with. The ground-based medical support those are companies that contract with basically every major commercial airline that we're all going to be flying on. And they are staffed by physicians who are experts at flight medicine and what is available on the flight. They also know that this is not our normal environment, that we are nervous and scared, and that we probably have not seen this in a long time, if ever. So their job is to walk us through everything. One thing to remember about speaking with that ground-based medical support is, again, we're not in charge of that. And so while I have heard of some people being able to speak directly to the physician on the ground, that's not always the case. And it could be that you speak to the flight attendant who calls up to the pilot who calls down to the ground, and then you get this, little relay telephone system going. So it's possible that that's going to happen. But before going through any interventions of any kind, I would just call that ground-based support. My job is to go and assess the patient, say, here's what I think is happening. Help me figure out the next step.
And kind of a follow-up question to that real fast. When you do talk to that ground-based support, do you generally just follow whatever they say? For example, if you are a physician who's usually used to getting or receiving the questions or receiving presentations, then making medical decisions, do you actually just say, hey, I'm going to turn off that script. I'm going to follow whatever you want to do. So if they say, they ask you the question, what's the symptoms? You say, these are the symptoms. They say, check the heart rate. You say, I'm going to check the heart rate, almost as if you were in the operating room that way. Is that generally how you approach it, or is it more of a shared conversation as you move forward?
So I've never had to actually be the one talking to that. The medical emergencies I've had have been relatively simple. They've basically all been syncope, except for the woman that was on the ground before we left, and we just handed her over to EMS. So I don't know what happened to her. But that conversation with the ground, honestly, again, they know that this is not your area of expertise, that you are not prepared to be doing this. They are perfectly happy to have somebody who can use the right medical terminology to help describe things and to direct things. I think I personally would be more than happy to give them the information, do what they say. If they tell me to do something that I'm not comfortable with, I would not do that particular thing, and I would tell them that. If you feel that you have a little bit more expertise, or you're a little bit more comfortable with suggesting a potential intervention based on what you see there, I think that having that shared decision making with on the ground physician would be perfectly acceptable.
So if this patient, it's determined that they need more medical care than can be provided in flight, who ultimately is making the decision to change course for the flight or even ground the plane?
Yeah, so the decision to divert is not ours. Again, I don't know how many times I can say we're not the ones in charge, which is good and bad, right? So we don't have to make that decision, and we can't make that decision. It's ultimately the captain's decision as to whether or not she or he can or should divert the plane. And the captain has to take into consideration a lot of different factors. One is the cost of a diversion. So a diversion can actually cost upwards of $1 million depending on the type of plane and where the diverting to. And while nobody likes to think about money when we're trying to help a person, that is something that they have to take into consideration, not us. They also have to take into consideration things in the air when they are deciding whether or not they should divert. So weather conditions at a possible diversion site versus the final destination site. They have to think about air traffic control flow at the possible diversion site or the destination site, and what other air traffic or high priority planes might be in the air at the same time. they have to think about the actual landing weight of the plane. A fully loaded 767 that is fully fueled and has just taken off can't just come back around and land immediately. They're going to have to dump fuel, burn off some fuel, do something, especially if it's even at a higher altitude, which makes it harder for a plane to land. And then they have to think about what are the conditions down on the ground that they have to take into consideration. They have to think about runway length. Again, a 767 can't land at just any runway. It has to have a long enough runway, which is why we see them landing at the major airports and not the minor airports that we'll fly in and out of. They have to also think about what facilities are on the ground to turn that plane around. Do they have the fueling trucks, the jetway, et cetera, to even get somebody off the plane? That particular airport might not have it. And then they also have to think about what medical facilities are proximal to any potential diversion airport. Just getting a patient on the ground isn't going to do any good if they're not near any type of medical facility that's going to be able to take care of that patient. So that's why ultimately we can make a recommendation, but the final decision is going to be up to the captain.
So let's take the syncope case. Let's take the case where, hey, maybe you're a little bit dehydrated, just need to lie down, get that blood back to the brain. We'll give you a little bit extra water and see how you do. We make it to our final destination. They say, hey, let's not divert. This person doesn't need door to balloon time in 90 minutes. It's going to be okay. Let's talk a little bit about what our responsibilities are once the plane's landed. So what do you do next? You were the person who helped. What are your roles here?
Yeah, so, it can go a number of ways. If the patient felt fine enough to go back and sit in their seat, then they're free to decline any kind of medical support and they can just get off the plane and go. That's one possibility. It's possible that the airline might ask you to provide a little bit of documentation or fill out some of their paperwork. That's going to be the airline's purview. If they asked me for it, I would. Some things that you can do if there's EMS actually coming in on the plane and you feel like you need to talk to them. Remember, I talked about having a blank piece of paper and a pen to write down some of your interventions or vital signs or something like that. Hand that over to EMS. That might be helpful to them as they're continuing to take care of the patient. And also, one thing you can always think about, if there was some kind of change, physical change that you were able to capture with pictures on your phone or something, maybe you could give those to EMS as well to give them an idea of what assessments happen at altitude versus now when the patient is back on the ground.
Let's say that person is okay, and now they want to thank you with a monetary gift. Do you accept that, or does the airline offer you free miles or a first-class ticket for your return flight? Is it okay to accept those?
So this is always a sticky question to answer, right? The Aviation Medical Safety Act that I mentioned, or Civil Medical Aviation Law of 1998, basically says that the Good Samaritan protections in that law are in place as long as the physician or medical volunteer is not acting out of an expectation for being compensated. So I think that that's a key word in there, is that it's not expected. It's not asked for ahead of time. It's not been decided upon ahead of time. I have heard of people taking that in several different directions. The miles are all, the whatever compensation sometimes airlines give you, they always come with the fine lines that say this has no monetary value. So that could potentially be argued if you want to accept it or not. A cash offer, I'm not sure I personally would feel comfortable accepting a cash offer. I've had medical emergencies where nothing happens and I walk off the plane and that's what happens. I've heard of people getting, a bottle of wine or something like that. Again, it's not expected. It was never asked for ahead of time. But I think the main thing is you do what is in your best judgment, what you're comfortable with.
So you're saying that I can't bill for a level 5 note and send it to them?
No, I don't think so. I don't think that's going to fly.
Still got to write a note, though, apparently.
That's good to know. You might have to write a note. And so as the expert, I know you've given talks, you have all this experience with aviation and things like that. What are we missing? What are some other things you really want our listening audience to know about emergencies in the air and how to address them? What else have we missed? What are things you want us to know about?
One question that comes up often, and I have to say, I don't want to be known as the expert. I want to be known as the expert in being a non-expert in this subject matter, right? Because I'm not a flight medicine physician, so I'm like the opposite of that. So, but one thing that does come up a lot that people will ask about is, do I need to prove anything to the flight attendants that I am a physician? Or I hear, I was on a flight and they wanted me to show them my medical license and wouldn't let me help because I couldn't prove it. The airlines don't really have any kind of policy that says it must happen or it must not happen. And I say that only because I've seen it go both ways with all the major carriers. So all I can say is I personally would not get offended if somebody said, I need you to prove that you're a medical professional. I mean, think of it from their standpoint. They're trusting random person from 15C to step up and help their customer. How do they know that 15C is actually somebody who knows what they're doing, or they're just pretending because they watched a bunch of medical shows? So I personally would not get offended by somebody asking me about that. And you can do various things. Sometimes I have my badge in my purse just because I have my badge in my purse. I do I used to have a pocket size version of my medical license because my state used to give those out. I think I have a picture of various certifications that would probably suffice as well. So I'd recommend having some kind of documentation or picture of it if you feel like you might want to respond, and to take no offense if somebody is asking for proof.
I actually do have a question about that. This is how my thought process went. So the first thing I thought is like, well, you can just Google me, right? Here you have my name on my on my thing. Most of the times you Google me and it comes up with.
You'd have to pay for in-flight Wi-Fi, man.
That was going to be my next question. So that's exactly how I went next. So I was thinking, especially a lot of the medical resources that I use are on the internet, and especially if it wasn't in my field of practice, I would definitely want to use the internet to help me. Do you know whether they can either gift you internet so you can do that, or whether it's really okay to turn off your airplane mode when you're the responding provider? Has that come up as a topic of conversation yet?
So whether or not they would gift you anything, I have absolutely no idea. Can't answer that one. A couple things to take into consideration are that, in-flight Wi-Fi only works within 200 miles of the border of the U.S. So when you're flying over, sometimes when you're flying over oceans, your Wi-Fi might not work. As with regards to turning off your airplane mode, well, I don't recommend that. And even if you did, nothing's going to happen because there's no cell towers. All the communications equipment that's available on the plane, your cell phone's not going to be able to tap into that. So if you turn off your Wi-Fi or turn off your airplane mode, you're just going to drain your battery, and your phone's not going to find anything.
So we're gonna have to trust the ground crew can use the internet to look these things up if I can't do it.
There are some apps that you can download, and I won't say the name of any apps, but there are apps available in the app stores that will give you, if you download it ahead of time, it's going to give you information as to like what medical equipment should be available. It actually takes you through the steps, gives you a lot of likely scenarios, talks about what you should do for the likely scenarios, gives you actually a place to do some documentation if you want to. So there are some helpful apps that don't require current Wi-Fi or internet connection that if you, again, are interested and, want to be prepared, you can think about downloading that onto your phone.
I guess we're getting close to the end. And before we get to take-home points, I really want to know, so one of the very first movies I ever watched that had a physician on board where they were dealing with emergency was Airplane, the movie. Is there anything that we should not take from that movie into our practice?
Everything.
Okay, excellent.
Glad you asked, right?
I just wanted to make sure we made that clear to anyone who was listening to this episode.
What a great movie, though.
It is. All right. So now that we're sort of at the end, I just want to make sure, do you want to provide any lasting take-home points for our listeners before we sign off?
I think it's just always important to remember that as you're approaching this, just remind yourself you are more qualified than anybody to at least look at somebody and make an assessment. Always take your own pulse as you're heading up to see or heading back to see the patient, just like you would in any other situation. And that you're never, ever alone in any of these scenarios. If nobody else is there, the flight attendant is going to be there. They're pretty good at keeping calm under pressure. That is what they do all day. There's always that ground-based medical support.
Excellent. Thank you so much for spending time with us tonight. I definitely learned a whole bunch, and now I feel more equipped and more ready to take care of any emergency that happens next time I fly.
It's been a lot of fun talking with you guys and going over this. I know this comes up time and again. And so it's really fun to, just talk about aviation. And I love talking about planes and flying. And I love talking about medicine. And even though there's not a lot of pediatrics in this talk, I think it's like the anti-pediatrics talk that all the pediatricians need to hear, because we're all terrified of those patients that are 18 and older.
Absolutely. Well, thank you so much for spending time with us today.
Thank you.
This has been another episode of the Cribsiders. It's for the kids.
It's for the kids.
Get show notes and sign up for our bi-weekly Knowledge Food Formula Feeds newsletter on our website at www.thecribsiders.com.
We're committed to providing you with high-value practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts, or contact us at thecribsiders@gmail.com. Special thanks to our producer for this episode, Dr. Han Wen, and our wonderful social media team, which is mostly Denise Cruz on X, Blue Sky, and Instagram. I've been Sam Mazer.
And I'm Hong Win.
And this has been Chris the Chi-Man-Chu. Thank you, and good night. And for those who've made it to the end, you're not going to be treated to an AI poem, but we're going to do some quotes from one of my favorite movies, Airplane, the movie. So I'm going to start, and you're going to do the next line.
Yep.
Ha! You better call the captain. We've got to land as soon as we can. This woman has to be gotten to the hospital.
A hospital? What is it?
It's a big building with patients, but that's not important right now. And of course, my other favorite quote is when they're talking about food poisoning from fish. And of course, the doctor saying, it's extremely serious. It starts with a slight fever and dryness of the throat. When the virus penetrates the red blood cells, the victim becomes dizzy, begins to experience an itchy rash. Then poison goes to work on the central nervous system, severe muscle spasms followed by inevitable drooling. At this point, the entire digestive system collapses, accompanied by uncontrollable flatulence, until finally the poor bastard is reduced to a quivering, wasted piece of jelly. You guys can YouTube the whole scene. It's fantastic. Have a good one, guys. Bye.